So good morning. This is March 19th, a Tuesday, and it is our local learning community around the topic of perinatal mental health. So welcome to the space. Please add your name and agency to the chat. And the agenda is also linked there. Thank you to Laura from our operations team for sharing the slides. And we'll just jump right in. So if you wouldn't mind going to the second slide, Laura. So for those of you who might be new, what is a learning community? What is the space we are in this morning? So we, the MCH local support team, create a space for you to be together with colleagues from across the state to learn from one another's implementation of the maternal child health priority work, to connect and collaborate and share both successes and failures with one another. We know members of this community have much to learn from one another, and we're honored to be space holders for you all. Next slide, please. So the meeting objectives of this particular topic around perinatal mental health is that you would learn about what that means for folks in Colorado, recommendations around systems improvement, and here's some on-the-ground community collaboration training and capacity building. Next slide, please. We will have three presenters today. We'll kick it off with Jessica Bass, our maternal mortality prevention program manager here at CDPHE. She's going to review some of the data and recommendations out of the Maternal Mortality Committee. Then we'll move on to a perinatal behavioral health ambassador program for Latina communities from Susana Ariola with Cuenta Conmigo in the Denver metro area. And finally, Ginger will finish us off with some practical tools, low effort approaches, and an elevator speech about how to talk about perinatal mental health with your partners and community. Next slide, please. So just to get us warmed up in the space, it's always helpful for presenters to understand the audience level of familiarity with the topic. So we have two poll questions for you. The first one is, how familiar are you with perinatal mental health needs in your community? So its prevalence, who it affects, the resources available in your community. How familiar would you rate yourself on a scale of 1, not familiar at all, to 5, very familiar? Looks like we're getting a bunch of responses, kind of a range of answers. I'd say most of us are spread between 1, 2, and 3. Which is great to just get a sense of your familiarity. The next poll is, give one more second if anyone else wants to answer that first poll. Okay, the next poll question is, perinatal mental health is a concern in my community. Do you strongly agree with the statement? Agree, somewhat agree, disagree, or not sure? How important is this topic in your particular community? See, most people are agreeing and strongly agreeing. I'm sure that's why you're here. This feels like an important topic, and I look forward to diving in with you. Yep, most of us agree. 14 out of 28 agree, 6 strongly agree. And some folks are not sure. About 70 are not sure, which is also a fair assessment. And we can talk a little bit more about that data and how to find out what that means for your community. So, okay. Next slide, please. So very briefly, I just wanted to ground us in the topic of perinatal mental health and how it's important to our work in maternal and child health, and why are we having this conversation. So I'll be very brief, but perinatal means the period all around birth. So perinatal mental health refers to a birthing parent's health throughout pregnancy and the 12 months after giving birth. Though partners and other family members can be affected by perinatal mental health disorders, something I know Ginger will speak to later. And parents of every culture, age, income level, and race can develop perinatal mental health disorders. with or without life stressors. So it really can show up for anyone. Symptoms appear anytime during pregnancy in the first 12 months after postpartum. And these symptoms are more intense than what is commonly referred to as the baby blues, the period of kind of hormonal adjustment following birth, where birthers can be tearful or fatigued or emotional for a few weeks. It is really, these disorders are really not a part of normal pregnancy or postpartum experience. And though we hear postpartum depression thrown around a lot as the term that folks are talking about, really there are actual several forms of illness that parents can experience. So these include perinatal anxiety, OCD, postpartum traumatic stress disorder. There's an increase of diagnosis of bipolar disorders during this time frame, and much more rarely postpartum psychosis. So I'll drop a link if you're interested in learning a little bit more about that, just as background information in the chat. But though these disorders are relatively prevalent, an estimated 15 to 20% of birthers, according to Postpartum Support International. Unfortunately, these conditions can be really stigmatized, making it difficult for individuals to ask for help. We know that about 50% of birthers or mothers will never seek treatment, according to one calculation. So why is this important? What are the consequences of untreated perinatal mental health disorders? Well, during pregnancy, it means a birther is more likely to have several medical conditions, hypertension, gestational diabetes, preterm birth, and other poor outcomes. And then in postpartum, untreated perinatal disorders can lead to affect lactation, bonding with baby, able to care for self and others, long-term consequences for child emotional development and behavioral problems. And as Jessica is going to speak to in just a second, also linked to a risk of maternal mortality. Next slide, please. So we're about to jump into Jessica's data around some of the worst case outcomes of perinatal mental health. So I think it's just important to ground ourselves in the ultimate message that this affects a lot of people, but there is help. Some of the pregnancy-related depression and anxiety disorders can't be fixed overnight, but they can be treated. There's effective, well-researched treatment options to help folks recover. And those treatment plans are different for each person, but could involve increased self-care, support groups, therapy, counseling, treatment of symptoms with medication when necessary. So with that, I'm going to turn it over to Jessica to kick us off and get into some of the data.
Thanks, Reed, for that really important grounding. I appreciate it. And thank you all for having me here in this space today. Next slide, please. So I'm going to be giving a very brief overview of our maternal mortality data here in Colorado. But I just want to take a minute, and Reed kicked us off really well, but kind of to talk about setting the stage for why we need to pay close attention to maternal mortality. Maternal mortality is often thought to be a key indicator of the general health of a community. So we know that while maternal mortality, thankfully, is relatively rare, the rates of near misses, morbidities, and the overall health complications that Reed spoke to during the perinatal period are great. And these complications not only impact the birthing individual, but the child, the family, and the entire community. And we also know that maternal mortality disproportionately impacts certain communities, and I'm going to talk about that more today. And you've probably seen this in the news, but while the US, while spending more than any other country, any other economically developed nation, we have worse outcomes than similar countries. So it's something that we really all need to be paying attention to. And we know that maternal mortality, we often talk about it as the tip of the iceberg. So what that means is, while our committee makes recommendations to prevent future deaths, we know that if we were to enact these recommendations, we would not only prevent future deaths, but it would really trickle down, and it would impact, it would overall improve the health and well-being of our maternal and child health population in general. So next slide. So I'm going to get into the data, but first, some of the terminology. So a pregnancy-associated death is a death, this includes all deaths that occur during pregnancy or within 1 year of the end of pregnancy, regardless of the cause of death. So pregnancy can end by live birth, stillbirth, fetal death, miscarriage, or abortion. And the Colorado Maternal Mortality Review Committee reviews all of these deaths. And for the purposes of this presentation, all pregnancy-associated data is in blue. Next slide. And pregnancy-related deaths comprise a subset of pregnancy-associated deaths. And those are deaths where the pregnancy is due to a pregnancy complication, a chain of events initiated by the pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. And that's the CDC definition. It's a little bit complicated and wordy, but we like to simplify it in our community and say that the committee determines that the individual would not have died had they not been pregnant. So pregnancy-related deaths, they're due to a variety of causes, including, of course, things that we might typically think of like hemorrhage or a complication from a C-section. But now we also understand that there's other pregnancy-related causes that maybe historically we haven't thought about as being pregnancy-related. So for example, if a person does develop postpartum depression, like Reed talked about, and then later were to commit suicide, or if they were prescribed opioids and after a C-section and then later overdosed, those deaths would also be considered pregnancy-related. And for the purposes of this presentation, all the pregnancy-related deaths are in green. Next slide. And one more click. Thanks. Okay, so from 2016 to 2020, we had 174 pregnancy-associated deaths in Colorado and 80 pregnancy-related deaths. So that gives us a pregnancy-associated mortality ratio of 54.7 and a pregnancy-related mortality ratio of 25.1. So we use mortality ratios when we talk about maternal mortality, which represent the number of deaths per 100,000 live births. And we use ratios because we're talking about relatively small numbers, and ratios allow us to compare the proportion of deaths within and among certain populations. And we'll see this in a second when we talk about race and ethnicity differences. Next slide. So this is looking at the pregnancy-associated mortality ratios over time, and you can see that unfortunately in 2019 and 2020, we are seeing an increase in the pregnancy-associated mortality ratios. Next slide. So this graph shows the number of maternal overdoses in the past several years. So this isn't a ratio, this is the actual number of deaths. Overdoses are in part definitely driving the increase that we're seeing in our overall maternal mortality data. We're moving in the wrong direction when it comes to overdose. We've not yet completed the death reviews for 2022, but we do have preliminary data and we see a significant jump again in 2022. A lot of this is driven by fentanyl overdoses, but like I said, we are overall moving in the wrong direction here. Next slide, please. So when we look at our data, overall, we see that approximately 9 out of these 10 deaths are preventable. And a death is considered preventable if the committee determines that there's at least some chance of the death being averted by one or more reasonable changes at the patient, provider, facility, systems, or community level. Next slide. Okay, so like I said, there are disparities when it comes to who is impacted by maternal mortality. So the pregnancy-associated mortality ratio for those who are American Indian, Alaska Native was 2.9 times higher than the overall ratio. This means that American Indian, Alaska Native individuals were 3 times more likely to die during pregnancy or within 1 year postpartum than the overall population of those giving birth in Colorado. Next slide. And the pregnancy-associated mortality ratio for those who are Black was 1.9 times higher than the overall pregnancy-associated mortality ratio. So this means that Black individuals were 2 times more likely to die during pregnancy or with 1 year postpartum than the overall population of those giving birth in Colorado. And we see these same trends at the national level as we do in Colorado. I didn't include this data, but we know that a significant number of deaths we attribute that discrimination was a contributing factor. I want to be really clear that our reviews show time and time again that this is about racism, not race, being the contributing factor here. So next slide, please. So again, we continue to see disparities among pregnancy-related deaths. Those with Medicaid as a payment and delivery were 2.5 times more likely to die from a pregnancy-related cause than those with private insurance. And studies suggest that this inequity, studies suggest, and we hear from people with lived experience, that this inequity is not due to Medicaid coverage being subpar, but rather there's significant health inequities and increased mortality among those with lower socioeconomic status. This is due to systemic factors and social determinants of health rather than individual factors. Next slide. And we continue to see inequities when we look at region of residence. So among pregnancy-related deaths, those living in frontier counties were 3.6 times more likely to die from a pregnancy-related cause than those living in urban counties. Next slide, please. Okay, so I know we're all here today to talk about perinatal mental health. And what's the connection with perinatal mental health and maternal mortality? So you can see from this data that our leading causes of death are suicide and unintentional overdose. So the blue again represents all of the deaths of the perinatal timeframe, and the green shows the subset that the committee determined were related to pregnancy. So again, suicide and unintentional overdose being those top leading causes. Next slide. And we see that overall, mental health or substance use were factors in 1 of every 2 pregnancy-related deaths. And then we also we see that even among deaths that were not due to suicide or unintentional overdose, mental health or substance use contributed to 1 in 5 of those deaths. So that might be a case where mental health contributed to delay in the decedent receiving care. And then they later experienced a health complication that could have been avoided had care not been delayed. Next slide. So earlier I said that 89% of deaths were preventable, but the committee determined that among suicides and unintentional overdoses, 100% of those deaths were preventable. Next slide. Okay, so like I said before, mortality is really the tip of the iceberg. If we do things to prevent maternal mortality, we will improve the overall health of our MCH population. In this report that the committee released last year, there were 13 categories of recommendations that you can see laid out here. I can't go through all these today, but I do want to share one initiative that came out of the review committee, and it's related to overdose prevention, provider training, and reducing stigma, bias, and discrimination. Next slide. So in partnership with PSI Colorado, the University of Denver, and the Behavioral Health Administration, we developed a training for anyone working with the perinatal population. And the data shows just how common the intersection between perinatal substance use and mental health is, and that there's a significant subset of people who are using substances to cope with mental health symptoms. We also know that our mental health and substance use treatment systems are often fragmented, and we know that individuals who are trained in perinatal mental health, they tell us they often don't feel equipped to screen for, diagnose, or treat perinatal substance use. And perinatal, as much as mental health is stigmatized, perinatal substance use remains, I'd say, even more stigmatized. There's fear of punitive measures, a potential loss of custody of kids. There's historical implications in terms of how certain communities of color have been treated, and making it even more fearful to talk to providers about this chronic health condition. So we know that our Colorado data obviously shows that unintentional overdose is the leading cause of maternal mortality. So we have a vision that every perinatal mental health professional will have the skills to screen for and treat maternal substance use. And frankly, that all professionals working with the perinatal population will have the knowledge and skills related to maternal substance use to screen for and know the appropriate follow-up. Because we know when providers aren't willing to talk about it, it further stigmatizes the issue and people don't get the support they need. So we first offered this training last year. We opened it up to 75 individuals, and it was full within the week. I just say that because I think it really speaks to the need and the hunger for this information on this topic. And I'm sharing it with you all today because it's a training that could be part of your MCH action plans. Feedback from participants has been overwhelmingly positive. It can be adapted kind of to any budget or any community's needs. We've done this as a 1-hour lunch and learn, and we've done it as a multi-day advanced clinical training, both in person and online. We've done it to a variety of audiences, from those who are have a lot of perinatal mental health training to those who are really working adjacent to this population, like front desk clinic staff or childcare workers and kind of everybody in between. So if you'd like more info, you can reach out to me and my contact info will be there in a minute. But next slide. So here's a link to the full report. Like I said, really just gave a very quick snapshot today. But the takeaway message, one of the takeaway messages is that we really want this data to be out there and available and transparent. And if you'd like more of this data, we typically can't share data beyond the we can't share it like at the county level, can't share it beyond urban, rural, or frontier just because of small numbers and confidentiality. But we would love to find ways to individualize this data and make it meaningful for you and your community and maybe pair it with other data sets that are available. So please reach out and I'll put my contact info in the chat as well. So thanks for having me.
Thanks so much, Jessica. I also dropped the link to the Colorado Maternal Mental Health Collaborative and Framework where they listed that training. I know one just passed at the beginning of March here, but do you think they would repost that kind of on that site?
Yeah, I think they would. And I think like I said, there are a ton of ways to individualize the training and like bring it to your community and yeah, make it fit your needs. So.
But maybe folks should reach out to you as well.
Yes, people can reach out to me.
Perfect.
Thank you.
And then there's the full report with all the recommendations around systems improvements for maternal mortality in the chat as well. And then Jessica's contact information. And that was a lot to take in. So I'm going to transition us.
Yes, I threw a ton at you very quickly, so thanks. But I'm happy to talk more individually about this data or recommendations with any of you at any point. So yes.
Absolutely. And if you have any questions for Jessica, feel free to drop them in the chat and we can get to them after all three presenters present. We're hoping to have a little bit of time for Q&A. So be thinking of those questions and drop those in the chat or be ready to unmute at that point. Okay, we're going to shift gears to a little bit more of a community focus. So next slide. Oh, thank you, Laura. You're on top of it. So next, we're going to hear from one of the grantees of the Perinatal Behavioral Health Community Ambassador Program. Say that 3 times fast. This is a partnership which was aimed to reduce stigma and increase connections to community resources by disseminating positive behavioral health messages in partnership with trusted community-based organizations. So the Public Health Institute at Denver Health, with funding from the Denver MCH program, partnered with 2 community-based organizations, one serving Latine communities and the other Black or African American families. And these organizations reviewed existing public awareness materials, such as the Parent Thrive website, which is linked in the agenda, and pregnancy-related depression materials from CDPHE, also linked in the agenda. And they developed an evaluation plan to make these messages more relevant to their communities. Again, the 2 grantees were Colorado Black Health Collaborative, or CBHC, and Cuenta Conmigo. And today we are honored to have Susana Arreola from Cuenta Conmigo here to discuss their lessons learned and other supports that their organization provides to families around perinatal mental health. So Susana, the floor is yours.
Thank you. Hi, everyone. Thanks for the space. My name is Susana Arreola. I'm a certified community lactation counselor. I'm one of the co-founders of Cuenta Conmigo Co-op. We are a cooperative created by 5 powerful group of Latino women. I'm the only one here today, but their names are Esther Caldero, Cynthia Zapata, Lucy Huereca, Paulina Eresis, and myself. On behalf of all my colleagues, we want to give you a special thank you to Reed from CDPHE for this opportunity to present today, and to Kelly Steinbach from the Community Health Promotion Division, Behavioral Health Program Public Health Institute of Denver Health, and the wonderful support of Mary Margaret from Jeffco Public Health. Probably she's here. And now I'm going to tell you a little bit about what we do at Cuenta Conmigo. Next. The other one, yeah, thank you. Cuenta Conmigo Co-op is an inclusive group focused on maternal and child health that supports and strengthens families, communities, and organizations to achieve health and well-being for all. We started as a community group in 2019 through a partnership with Jefferson County Public Health. We had the support as well of Colorado State Parent Coalition, and Cuenta Conmigo emerged from the questions and interest from community members, particularly from Latina families, neighborhood childcares, and other community members that were interested in supporting families to breastfeed their babies. After a massive response from COVID, we focus our attention to help families during the pandemic. No? We help them with resources. We participated in food bank distribution, and then after 2022, Cuenta Conmigo joined the Work Incubator project with Edgewater Collective. In September of 2023, Cuenta Conmigo became an official cooperative business upholding the values of equity, collaboration, and community. I'm going to talk about some of the activities that we do. We focus, stay in the same one, thank you. We focus on immigrant communities, mostly Latina American Spanish speaking at this point, but we have worked with families from other ethnic groups as we can easily relate to their experiences despite their language barriers. Our activities that we, or some of the services that we provide, we host free community groups and direct supports for parents. We do home visits or virtual interactions with families. We develop a lactation, nutrition, and mental health messaging and curriculums adapted to the interests and needs of the Latino community. We offer trainings to support child development, breastfeeding, and community emergency preparedness to community members, groups, and child care providers, including community lactation counselors and a pathway to achieve the IBCLC certification. We offer also consulting services for organizations, including research and data analysis to inform programming and support families effectively. We are also we're members of the United States Breastfeeding Committee, and we organize also, we are recognized as a breastfeeding peer program by the International Board of Lactation Consultant Examiners. Next, please. Okay. In March of 2023, we were invited to be part of the Mental Health Ambassador with the Perinatal Behavioral Health Community Ambassador Program. The focus was on promoting emotional well-being and reducing behavioral health stigma during pregnancy and postpartum by integrating community voice. So what we did is that we had 20 participants during this study. It was a photo voice study. We asked participants to share with us 5 pictures that were taken within the 3 days. And they sent us pictures from their babies, from events, friends, laundry baskets, piles of dishes in their sinks, themselves and their homes. Then we meet with each of them and ask them questions about the pictures they choose and they share with us. It was a great experience. I was one of the interviewers. It was an amazing experience to know more about those families and about what they were passing through. And then we asked them to reflect or make recommendations to improve the materials the maternal and mental health campaign have developed years ago. The interview lasted for about an hour, and they also receive a compensation for their time. And the themes that emerged were the following. Breastfeeding support in our language and all places. Family support and so much more. Estamos solas, we are alone. The power of companionship. My baby is growing, my family is growing. Next. Based on those themes and our conversation, we developed some messages and narratives that we believe are important to consider. Some of the messages are recognize our collective culture, values and accounts for moms' multiple roles in their family and their communities. It speaks of the fact that moms are many times alone. Integrate mothering the baby in the context of family life. So if you can see, we have designed these stickers that we usually carry with us to the events, or when we do activities with the families, or when we do home visits. Here is one that is here in this car, this toy car that says, "Eres el motor de tu familia, déjate cuidar. You are the engine of your family. Allow others to take care of you." We also developed some other things like, todas las mamás en algún momento necesitan un descanso. All moms need to rest in a certain point. Para cuidar a tu familia, déjate cuidar. Tu salud, tu alma y tu corazón son importantes. To take care of your family, allow others to take care of you. Your health, your soul, and your heart are important. Next, please. There are other examples of also, we share this. There are some, this is a special picture that we took with one of our mothers that participated on the study that is caring two babies, no? And it is one of the pictures that she shared with us. And the post says, eres el motor de tu familia y a veces también necesitas descanso y apoyo. You are the engine of your family, and sometimes you too need to rest and support. And we did another one that says, cuidas a tu bebé día a día y quién cuida de ti. You take care of your baby every day, and who takes care of you? Some of the answers here are my mom, my group of friends, my sister, my faith, at my work, they support me. And there is a tiny one that says myself. Cuida tu familia, déjate cuidar. So take care of your family allows others to take care of you. Next, please. Sorry. And also we have been creating some more activities around these initiatives. And we have our virtual groups, our in-person groups. We also have developed a training for people that take care of children. And also we have our one-on-ones with families that need special support, more personalized. Next, please. And here is our webpage. If any of you would like to connect with us, I'm gonna put it on the chat as well. And we have a referral referral form inside the webpage where you can directly refer families to receive our services that are completely free for the families. And also we offer classes on infant and toddler nutrition, infant mental health, emergency preparedness, and lactation consultant. We can help facilitate research, data collection, analysis, develop, and recommendations. And I think that is all the information that I have for you. Thanks again. And I will put my contact information also in the chat.
Thank you so much, Susana. When you said you're the motor of your family, let others take care of you, man, you said it with such earnesty in it. Like I got a little emotional, like it's a mom. What a beautiful message. And if I understand correctly, you are willing to share these materials and these messages that you developed. Obviously, you can't print them, pay for printing, but you're willing to share them with other groups if folks wanted to print them for their communities or for their outreach. Is that correct?
Yes. You just need to contact us, and we are happy to share this information. I think those the messages that we created were based on those conversations that we had during this study. So they are unique or very authentic messages that community identifies with them.
Wonderful. And if you're curious about how the Public Health Institute at Denver Health interacted with these community-based organizations and asked them to review these perinatal mental health resources and messages and create a campaign that felt good to their community, Kelly Steinbeck Tracy said she would also share the scope of work and the project description too, if that feels like it's something of interest, that there was a community-based organization in your community that you wanted to check in with about what are the appropriate perinatal mental health, behavioral health messages for that community. So thank you so much, Susana. Again, just really amazing work that you're doing. And thank you for mentioning that all the support you get from Jefferson local public health department around lactation too. You're so integrated into multiple aspects of maternal and child health. So.
And Reed, real quick, I see a question in the chat about, do families need to live in Denver or Jeffco to be referred?
No, we usually support families from statewide. We also have some in our virtual sessions. We also receive families from other parts of the state, no, or like even people have been connecting from other countries looking for support. Yeah, everybody's welcome.
Oh, wow. That's amazing. So amazing. Thank you again for sharing and taking the time, Susana, to be here. I'm going to transition us to our last speaker. Next, we're going to hear from Ginger Hilliard from Larimer County, and she's going to talk about some low effort, high impact ways of encouraging community dialogue around pregnancy-related depression and anxiety mood disorders, and what that elevator speech might sound like. Take it away, Ginger.
Hi, everyone. I just want to say Jessica's presentation was amazing, and it can also feel a little overwhelming looking at all that data. And I want to say, no matter what your maternal child health plan looks like, some of the work you can do in pregnancy-related depression, anxiety, mood disorder is what we really focus on calling it here in Larimer County, which Larimer County incorporates Fort Collins, Loveland, Estes Park. Next slide, please. We have been doing pregnancy-related depression, anxiety, mood disorder work for a long time and have had a lot of learning lessons along the way. But no matter what your maternal child health plan looks like, you can do a lot of different things in your plan or different activities that can meet the needs, or I should say, can make some impact in your community and be simple things that you can do throughout the year. So first thing I wanted to say is that one of the things that we have really focused on in our community is there's a lot of faces of pregnancy-related depression, anxiety, mood disorder, and this picture is one we've used a lot because sometimes the people who are impacted are the ones who are the woman on the left versus the one on the right. And what we see in the community is the doctors who screen people are they screen the one on the right because they're like, oh, the one who comes in looking disheveled is the one we're going to look at. And we ignore the one on the left. But really, the one on the left might be the one who's hiding her depression, her anxiety, mood disorder the most. So I want you to keep that in your mind that we as a community want to address and share this information with all people, because sometimes the people who are putting on the best front are the ones who are hiding their struggle the most, because they're working really hard to make sure they look the best. Pregnancy and on the postpartum period is challenging, and coming into an appointment or coming into the world looking a little disheveled is actually what we expect. Sweatpants and hair up in a ponytail is actually pretty normal. And if they show up with the makeup on and jewelry and hair perfect, that's actually who we should really be concerned about. But it's not how the medical world really looks at things, and we sometimes really overlook that. So that's my first message to really think about. And we really talk to doctors about that in our outreach, because stop only talking to people who look like they might be depressed or look like they might have anxiety. So that's my first little message. Next slide, please. And that of course goes with all the stigma and things that go along with depression. The single most concern for depression is a prior history. I mean, I'm sorry. The single greatest risk factor for pregnancy-related depression is a prior history of depression. So making sure that we touch base with people in our community about if you did have any type of depression before is very important, but it is not the only thing. And it definitely, people are impacted by anxiety, depression, mood disorder, even if they didn't have depression before. But that is an important message that we like to make sure people are talking about. The other piece about that is that people, this quote from Hurston, I won't say it, Motier, that people with pregnancy-related depression are less likely to report if they are feeling sadness than other people who have depression. Rather, they commonly have prominent feelings of guilt or worthlessness and experience a loss of enjoyment of usually pleasurable activities. So people who are having depression in that pregnancy or postpartum time are really struggling with that more than in other times of life, because everybody's telling them, you're supposed to be happy. You're supposed to be joyful. This is supposed to be the best time of your life. And inside, they're feeling sad and they're feeling depressed. They're feeling anxious. They're feeling the pressure of the world about providing for this baby. And so it is really a challenging time. So even if you're not doing any type of social emotional support in your MCH plan, it is just so important to, if you're doing HCP work, if you're doing information and referral, if you're doing any type of work in the community, if you can share messages around this work, keeping in mind that the data that Jessica shared, keeping in mind some of those pieces of data that the suicide and other things that might not be a huge lift if you can get it into different newsletters or other things. So I'm sorry, I'm getting ahead of myself. Next slide, please. Okay, in our community, we do still have a coalition, and our coalition is, does bring community partners together. Our community partners include medical providers, home visitors, mental health providers. And the purpose of that coalition is to share resources, share outreach materials, talk about upcoming events, build relationships, and leverage resources, because there is a lot going on in our community, but what we have found is just bringing people together to talk about what's going on in the community and asking community partners to do more has been a huge benefit of just seeing if there's the ability to build more around this work. And this doesn't necessarily have to be something that every community does, but it's something that we have continued in our community. And we have seen the benefit of just coming together, whether it be through a coalition or whether it be through just having informal lunch gatherings, to just talk about what are you doing related to supporting pregnant women or pregnant people, sorry, in your practice, in your services. Our Medicaid provider has started support groups for pregnant people and postpartum people. And so there's been some building of services just through talking about it. And so that is one way that we've done work through our MCH plan. But if you're not doing an MCH plan, there are a lot of other options. And so next slide, please. Our message in our community that we try our best to share with anyone we can share it with is that pregnancy-related depression, mood disorder impacts 1 in 5 people. Anxiety is reported by 1 in 3 people during the year after delivery, and 1 in 10 partners experience mood anxiety or some type of mood and anxiety disorder during pregnancy or after, or during the first year after, sorry. You can word any of that any way that works for you. A lot of what we hear from people is they don't always understand. And so breaking it down into very simple sentences that you can spout off in the community as you're talking to people is very helpful. The partners are very concerning to us because partners are feeling the pressure of being a provider. They're not the one who is pregnant. They're not the one. So they tend to minimize the concerns that, because they feel like they can't speak up. So if they are feeling any type of depression, OCD, anxiety, or anything, they're not usually going to speak up because they're like, it shouldn't affect me. But we do see suicide and we do see depression and concerns because they're feeling like they need to make more money. They feel like they're concerned about providing for this new growing family. And so it is very, very concerning for all partners in a growing family, whether it's a birth or an adoption or any way that a family's growing. Anxiety in that postpartum period is very concerning also. That people are self-reporting that 1 in 3 people have anxiety in that 1 year postpartum. We have verbally had people tell us after they've had a suicide in workplaces in our community, oh, we didn't know that would happen a year after birth. Like, there's a lot of misinformation in the community, so we're really trying to get people to talk about it. And when we share these messages through all of the different ways, we are trying to get people to share it with others. And so the ask is, when we share these facts, is would you be willing to share that with your friends, your family? Because we can't reach everyone through MCH in our community. But if I share it with someone at an event, would they be willing to go share it with 5 of their friends? Would our community agencies be willing to talk to all of the people that they serve. Because those suicide numbers that Jessica shared are very, very concerning. The substance use, the overdose numbers are very concerning. And I think if we as a community can start to talk about it more, and this is what we talk about in a lot of the outreach we do, is if we all as a community start to put our arms around pregnant and postpartum people and partners, we as a community can start impacting this more because we're talking about it and we're checking on people more often. Next slide. So we in Larimer County, we do outreach in many different ways. And I just want to share some of these because these are things that you could do locally and it doesn't have to be any or all of these. But we use the state PRD materials, and if you're not familiar with those, go check them out. And one of them were on Jessica's slides. Those are all available on the state website. And if you have any questions, you're welcome to reach out to Jessica or myself. We do, we reach out to families through care coordination information and referral through HCP. We also do tabling events. When we are doing information and tabling events through our HCP work, we also take all of our pregnancy-related depression materials and put them on the table. A lot of people don't want to come and talk to you about pregnancy-related depression, but we put it on the table and we will see people come up and take the materials. Having a whole table of PRD information, people aren't always going to come up and talk to you, but they will, if you have it with other stuff, they will take it with them. Or if I see someone who is pregnant or postpartum, have a baby with them, I will just say, hey, would you mind taking this with you? And would you mind reading it and sharing it with someone? Or I will give them one of those little messages. Hey, did you know that 1 in 3 postpartum people are affected by anxiety, mood disorder? Would you mind taking this and sharing that with 5 of your friends at a tabling event? And they're like, oh, okay, cool, I'll do that. So it's just trying to get it out there. We do library story times here to try and get information out and share information with community. We have a lot of luck sharing pregnancy-related depression information there. And about 2 times a year, I just do a little highlight about it. Community agencies, we do updates at those meetings, and those are just very simple, like 2-minute little updates a couple times a year. And then through informal and formal presentations like today and other community meetings that I can talk about it at. Anytime I'm doing presentations about HCP or any other health department stuff, I just throw in a 3 to 5 minute little talk about pregnancy-related anxiety, mood disorder, because it's just such an important topic. And the one other thing that I always share is if we don't have healthy moms or healthy parents, we don't have healthy kids. And it's just such an important part of the parent-child dyad. And so thank you so much for listening. If you guys ever have any questions, I have lots of lessons learned of things that have worked locally, and I would love to chat with anybody one-on-one about any ideas and things that have worked or things that have not worked over time.
What a lovely offer, Ginger. Ginger has been in the field for quite a while and has lots of wisdom to share. And I love how you highlighted, Ginger, kind of the role of bringing people together, that convening, that coalition, that spreading the message with your partners and having that community dialogue, and then how pregnancy-related depression shows up differently with pregnant people than it does with other people with depression. And that was a great point that I didn't know about. So thank you for those messages, those low-hanging fruit way to spread the word, and the oxygen mask of take care of yourself so you can take care of and have healthy family as well. Wonderful. So if you would go to the next slide, Laura. We don't have a ton of time left. I was just curious if anyone else wanted to share very briefly about other work that's happening in your communities around perinatal mental health. that you'd like to highlight, or if you'd like to drop any resources in the chat. We'd just love to hear from other folks, any reflections today on your takeaway. You're welcome to drop it in the chat or unmute as well in the last few minutes that we have for folks on the call. And is Kelly from Lincoln here? Looks like maybe she wasn't able to make it. I know Kelly was doing some work around perinatal mental health as well, and had wanted to share, but we'll have to do that for another time. Sorry, Ginger, did you have something?
Oh, I just wanted to say, related to Jessica's presentation, that Medicaid is going to be paying for doula services in the state of Colorado soon. I think it's July 1st. So related to some of the things that Jessica was talking about related to health equity, please encourage women, especially women of color, to take advantage of those doula services to help with some of those microaggressions and things they experience in healthcare in our state. Coming soon. It's super, super exciting resource.
Awesome. There's a couple things in the chat to draw your attention to. A link to Doula Care, building a coalition for support. Jessica also shared the real stories about pregnancy, parenting, and mental health. So that was a video series of pregnant people and postpartum people from the community sharing their story. And there's a YouTube channel with lots of those, and those are a great awareness tool as well. Am I missing anything else in the chat? Thank you for sharing. I didn't realize addressing mom's mental health was such a big part of our outreach. I learned so much time every time I come to one of these. Great, that's what we love to hear. And actually on that note, Laura, if you wouldn't mind just dropping the evaluation of this meeting in the chat. We love to hear if this topic felt relevant, if there's any way that we could improve, and then also topics for future learning communities. So what do you want to talk about in this space? This space is yours. So if there's something in your community that you would really love to learn more about, or you'd love to present about, we'd love ideas for future learning communities as well. And then in terms of our learning community schedule, I'm not sure if we've announced this officially yet, because local public health agencies are doing their action plans and budgets in May, and it's a busy time. We are going to be skipping our next slotted. So we have these learning communities every other month. So it's March, it would typically be in May, but because of all those deadlines around your action plans and budgets, we're going to give you the month off. And looks like we have contact information for Ginger. Again, if you want to take her up on her offer to talk about strategies in your community, you have that there. And I'm also going to link the agenda just one more time with some of those links to great resources. Postpartum Support International has a psychiatric consultation line for providers. They have free 101 trainings. They have a helpline for families. They have data. So that's a really great resource that I've used in the past. And I think, Ginger, you said that you use that one a lot as well. And we will also be sending out these slides in follow-up with links as well. If you want to put one takeaway before you jump off the call in the chat, thank you so much, everyone. I'm going to put my takeaway as that pregnancy-related depression shows up differently. Sorry, we ran out of time for the discussion, but put your takeaway there. I want to hear what the nuggets were that you took away from the presentation. Loved hearing about Susanna's work. Absolutely. Thanks, Sadie. Passion of the presenters got me excited. You can use short or small opportunities when interacting with community partners and providers to promote perinatal mental health. Importance of destigmatizing mental health and substance use so parents do not hesitate to reach out for much needed help. Absolutely. That statistics about half of folks not getting their help really stuck with me. PRD and mood disorders are way more prevalent than I realized. 1 in 5, 20%, so 1 in 5 women. And then 1 in 10 for partners. I liked that, Ginger. I didn't know that one. Okay, y'all, it's 12:01. Thank you so much for your reflections and for the discussion in the space. Have a beautiful rest of your Tuesday.